Welcome to the Crescent City, where Vital Options is in New Orleans with ASH, the American Society of Hematology. So while the public may not quite grasp the intensity of what public policy advocacy means, for someone like you, Scott, it's really in the trenches, because if there's a failure in public policy efforts, the ripple effect, I can't describe it. And I'd like now for you to expand a bit more as to where we're at today, because I'm going to guess that your work in public policy right now, as we enter 2014, is very, very different than maybe how it even was 5 years ago. Much of this is being driven by where we're at with the Affordable Care Act, and you take it from here.
Sure, you're right. It certainly has changed a lot in the last 5 or 10 years. And I think as an organization, the Leukemia and Lymphoma Society has invested almost $1 billion in research over the span of our existence to drive forward new cures. But a few years ago, we really got to the point we could say great progress has been made. But we also need to do some things differently. We need to engage more in advocacy. We need to engage ourselves in public policy, because there are two key places. We think about our policy agenda, our agenda, as cures and access. On the cure side, we need to do something differently in public policy to get them to patients more quickly, right? That process of development and approval is too long. So how do we accelerate that? So we need to engage with FDA and bring patient voices and talk about rapidity of research and clinical trial enrollment, new endpoints in clinical trials. And then on the access side, right, the issues have certainly been exacerbated or accelerated perhaps with the implementation of the Affordable Care Act. But we're talking about issues that have existed in the insurance market and are just, the challenges are accelerating. But these issues are all around for us: patient out-of-pocket expense, networks, meaning can I see my physician? And so one of our I'll give you an example of the focus point for us. Right now in every state, we're looking at these state exchanges created by the Affordable Care Act and saying, can a patient in New York who buys insurance through the exchange get to see Dr. Mauro? Is he in the network? And sadly, the answer is in a lot of those plans are no. And we can't have that for our patients. They can't not be able to go to the NCI designated comprehensive cancer center. They can't be not, in New York, several of the plans, there's a plan you could buy in New York. 0 of the 11 transplant centers in the state of New York are in that network. 0 of the 5 comprehensive cancer centers in New York State are in that network. As a cancer patient, we need to do some education, obviously, as an organization, to educate our patients to ask those questions, but then also to enlist patients, physicians, all of the advocate community to change that policy so patients can get access.
Dr. Mauro, Scott raises such important points. A curious question. Prior to the Affordable Care Act, access issues compared to where we're at now with the Affordable Care Act, what are some of the greater differences, or are there challenges and issues right off the bat comparatively that you could illustrate?
I can compare and contrast two different geographies. I practiced in Portland, Oregon for a number of years, where we had a different population and different access issues there, even without the Affordable Care Act. Really, geography and income disparity and minorities and different groups with little access or less advantage. And we had challenges. And as a university hospital, I think we, like many other, at Oregon Health Sciences University, my prior institution, needed to shoulder the burden, the gap, as best we could, and work and relied on advocacy to try to help bridge the gap. We now, I'm sure there's even greater strain and stress, although I think the Affordable Care Act was designed to help a little bit more, that exact population. And of course, in New York, there's a much greater diversity of patients' abilities. I'm very sad to know that that may be a reality for my patients, and I mean that's an immediate call to action that we need to, on the physician side, as an institution or as a group, inquire as to why and how we can change that, or to ensure that if not immediately accessible, that we're able to make sure that, like, patients who don't have access to us directly can have access to us by other means with other physicians, or organize yourselves as disease groups and disease treatment physicians to make sure that they get good care. So it's an immediate call to action.
And Scott, when you look at the exclusions that are now apparent, was this issue like this prior to the Affordable Care Act, or is it growing now in momentum?
I would say growing in momentum is a good way to say it. The issue existed before the Affordable Care Act. The challenge of, is my physician in network, was an issue before the Affordable Care Act. But because a great deal of the focus of the Affordable Care Act, again, public policy, the focus of that policy was to ensure a lot of folks who traditionally were getting primary care in an emergency room, so they were focused on, we need to keep premiums very low. And they weren't thinking about cancer patients. And that's a big part, as you said, the call to action is we need cancer patients' voices included in that discussion so that these sorts of policy decisions are not made.
So what are the plans underway? Thank you very much for both shedding light and giving perspective to some of the urgency that we face right now.
Thank you.
Thank you.
Thank you very much.